This is the anterior drawer test to assess for anterior instability of the shoulder. So I have my patient about 80 degrees of abduction and external rotation. Then I'm giving stability against between my shoulder and body. Then I'm coming into her axilla with my supporting, the hand that's going to give the force. And then I got my supporting hand on her coracoid and the spine of her scapula stabilizing right here. And I'm giving an anterior translation. Then I'm looking at my patient to see if there's any visual apprehension, also if there's any clunkiness. Okay, so this is the shoulder apprehension and relocation test, and a surprise. So basically what we're going to do is I'll have my patient in 90 degrees of abduction when it's lying on her back, and now I'm going to externally rotate her shoulder. I'm looking for apprehension in the movement, and so it's right here. So then come out of it a little bit. Now I'm going to give a posterior force, and now I'm going to do it again, looking to see if we can get increased motion before the apprehension, and that would be positive. And now I let go for the rebound effect and see if that happens. So now I'm going to be doing the load and shift test. I'm looking to see if there's any instability in my patient's shoulder anteriorly or posteriorly. So basically what I'm going to do is I'm going to secure on either side of her acromion. I'm going to come onto her humerus. And I'm going to shift anterior and posteriorly. And I'm looking for a signs of excessive shift either way. And I'm also looking for reproduction of her symptoms. And then I would also compare side to side, look for differences. Okay, so now we are about to conduct the jerk test. This is a test to assess for posterior stability of our patient's shoulder. I'm going to do this by taking my patient up into 90 degrees of flexion and internal rotation. Then I'm going to secure the back of her scapula. Now I'm going to take her into abduction as I give her an axial load, which then, if she had posterior instability, it would sublux her shoulder posteriorly, but she didn't. But because it's testing posterior instability, if there's a clunkiness or a reproduction of her symptoms, then it would be a positive test. This is the posterior apprehension test, and I'm looking to test the integrity of my patient's shoulder, specifically in the posterior aspect. So basically what I'm going to do is when her lying down, I'm going to bring her into flexion in the plane of the scapula. Then I'm going to give her an axial load as I bring her into internal rotation and abduction. And while I'm doing this, I'm looking for signs of apprehension or clunkiness, and if so, it would be positive for instability in the posterior aspect of her shoulder. This is the posterior drawer test. It's kind of like the anterior one with the hand placement, except now it's posterior. So I got my patient in 80 degrees of abduction and external rotation, nice and secure against my shoulder. Then I'm up in her axilla, and then I'm on her coracoid, securing on the spine of the scapula, and I'm going to give a posterior force. And again, I'm just looking for signs of instability or clunkiness. Also, if there's any apprehension in my patient, and if so, it'd be signs that her posterior aspect of her shoulder is not stable. Okay, so this is the sulcus test. It's to assess multi-directional stability of my patient's shoulder. So basically what I'm doing is I'm finding my patient's acromion, and then I'm finding where it drops off at, and I'm giving a downwards traction, and if the space increases to 2 centimeters or it reproduces her pain, then it's a positive test. This is the Hawkins-Kennedy test for shoulder impingement. How I'm going to do this is I'm going to bring my patient's arm up into some flexion, and then I'm going to internally rotate it, and now I'm going to give internal rotation force, and if it reproduces pain, then it would be positive for impingement syndrome. Okay, so this is the Zaslow's test, and it's to help me figure out if there's an intra-articular issue or a subacromial issue. So basically what I'm gonna do is I'm gonna have my patient come in at 90 degrees of abduction and 80 degrees of external rotation and secure the back of her shoulder. And I'm going to give her resisted internal rotation, and I'll say, don't let me move you, don't let me move you, don't let me move you. And I'll say, relax. And I'll come and give her resisted external rotation, and I'll say, don't let me move you, don't let me move you, don't let me move you. And now to interpret these results, if the internal rotation is weaker than the external rotation, it would be indicative of intra-articular issues.
Okay, did you delete it?
Yes. Okay, so this is the nearest test, and we're looking to see what's the problem child in my patient's shoulder. So first we're going to go into max abduction, and then we're going to finish off with some internal rotation, looking for pain, reproduction of the pain that they came here for, and then we'll come back down. Now we're going to externally rotate her arm, and we're going to do the same thing. This time we're looking to see if there's pain or discomfort in her AC joint. So if the pain is worse or problematic with internal rotation, then be indicative of a subacromial impingement. And then if it's worse in external rotation, then it would be indicative of AC joint issue. This is the supine impingement test. So it's just like the nearest, but now we're lying in supine. So I'm going to externally rotate and abduct my patient's arm, looking to see if there's any AC joint issues. Now I'm going to internally rotate, looking to see if there's impingement syndrome, and if this reproduces my patient's pain, then it would be positive for impingement syndrome. Okay, so this is the posterior internal impingement test. So we do this if my patient comes in, she's complaining of pain in her posterior shoulder, specifically at the end of her cock-up phase when throwing. So how I'm going to replicate that is I'm going to take her into about 90 to 110 degrees of abduction with some slight extension. And now I'm going to add my downward force right here. And if the pain replicates in her posterior shoulder, then it would be positive. So this is called the O'Brien's test. We are doing this to assess for the integrity of the labrum. So how we are going to do this is we'll passively take our patient into 90 degrees of shoulder flexion with some internal rotation and into horizontal abduction. And now I'll apply a downward force. This may cause the pain which our patient came here for. And now we'll open the hand up into relative external rotation and reapply that force. And so when reflecting upon the two forces, if it was more painful for the patient with the pain that they came here for, with their thumb down versus their palm up, then it would be a positive test for O'Brien's. The bicep load test 1 and 2 are two more tests to do to check for the labrum's integrity. So what we're going to do is we'll have our patient lying in supine. We're going to take her into 90 degrees of abduction with external rotation and supination. And now I'll ask my patient to not let me straighten her arm. Relax. Now we'll go into 120 degrees of abduction. And I'll say, don't let me straighten your arm. And relax. And if either one of these produces the pain which she came here for, then that would be a positive test for that. Alright, so another labral test that we're going to do is the anterior slide test. So what we're going to do is we'll have our patient sitting on the edge of the plinth like so, and I'll ask her to put her hand just slightly above her hip with her thumb facing backwards towards me. Now I'm going to stabilize at her clavicle and scapula, and I'm going to give a superior and anterior force at her elbow. And if this reproduces the pain she came here for, or if there was a clunking sensation or click, then it would be positive test. So this is the clunk test. It can be used to assess for general instability of the shoulder as well as for a labral test. And so what we're going to do is I'm going to make a fist and put it under the posterior aspect of my patient's shoulder. And now I'm going to take her into flexion with external rotation and abduction and rest her arm on my shoulder. And now I'm going to crank her shoulder over my fist, looking to produce a clunking sensation or to reproduce the symptoms which she came here for. And if either one of those happened, then it would be a positive test. So now we're about to do the Kim test. It is to assess for posterior or inferior labral lesion. So what we're going to do is I'll have my patient sitting in a chair with her back supported. Then I'm going to take her upper extremity and flex it at 90 degrees, supporting her arm and forearm. And now I'm about to apply an axial compression force. And if that reproduces the pain which she came here for, or if there was a clunking sensation, then it would be a positive test. So this is the labral crank test to check for the integrity of the shoulder labrum. And so what we're going to do is with them lying in supine, we'll take our patient to 120 to 160 degrees of abduction. Then we're going to give an axial load, and I'm going to take her through internal and external rotation, just like I would at the scalar test at the hip. And I'm looking for a clunking, clicking, popping sensation, as well as to see if it reproduces the pain in which she came here for. And if so, then it would be a positive test. Another labrum test that we are going to do is the resisted supination external rotation test. So my patient abducting her arm at 90 degrees right here, and then we're going to have the forearm in neutral. I'm going to ask her to supinate her forearm by trying to have her palm face upward. And as she does that, I'm going to bring her into external rotation. And if this reproduces the pain or the clunking or popping sensation which she came here for, then it would be a positive test. Okay, so this is the AC crossover test. If our patient comes in with complaints of pain around their AC joint, then we can see if this test replicates their pain by bringing them into about 90 degrees of flexion and full horizontal abduction. And if their pain is reproduced, which they came here for, then it would be a positive test. Another way that we can test to see if the AC joint is part of the problem which our patient is complaining of is the AC shear test. So what we're going to do is come down the clavicle and the spine of the scapula to the AC joint. Then we're going to apply a compression force. And then if that reproduces what our patient came here for, then it would be a positive test. So another way that we can test for the AC joint as the problem child is the Paxino sign. So basically what we're going to do is come with our thumb on the posterior aspect of the acromion, and then our middle finger and index finger on the middle clavicle, and then apply a force, a grip. And if that shearing force causes pain reproducing what the patient came here for, then it'd be a positive test. Okay, so now we're about to do the external rotation lag sign. So how we're going to go about this is we'll have my patient in 90 degrees of abduction and 80 degrees of external rotation. And now I'm going to take my hand away and I'm going to tell my patient to keep her hand still. And if her hand goes down into internal rotation, then it would be a positive test indicating that there's rotator cuff involvement, and then would most likely be an indication that the supraspinatus and or infraspinatus is torn. So this test is called the internal rotation lag sign. So to assess for the rotator cuff muscle, specifically the subscapularis. So basically what I'm going to do is I'm going to passively take my patient into internal rotation, and now I'm going to bring her hand off against her back. And I'm going to tell her that when I let go, I want her to hold her arm right here. And if for whatever reason she can't maintain this, then it would indicate that there is most likely a tear of her subscapularis. Okay, so this is the hornblower sign, another way to assess the musculature of the rotator cuff. So what I'm going to do is I'm going to take my patient to 90 degrees in the scapular plane, and she's holding a French horn. And now we're going to do resisted external rotation. And if this reproduces her pain and or she is weak, then it would imply that there is infraspinatus or teres minor involvement. And if so, it could mean that they have a tear of one or both of these muscles. So this is the belly press test. It's another rotator cuff, another assessment of the rotator cuff musculature. And basically what we're going to do is we'll test the subscapularis by way of creating internal rotation force. We're going to do that by having my hand on my patient's belly. I'm going to tell her with keeping her arms still to apply pressure onto my hand, constant pressure, and then if she's too weak to do that, or if she has to compensate by way of wrist flexion or shoulder extension, then it would be a positive test indicating that there's subscapularis involvement with her problem. Alright, so this is the drop arm or the dropping arm test. It is to assess for the rotator cuff musculature, and then it will be done by having our patient being taken up into 90 degrees of abduction. And then when I let go, I'm going to instruct my patient to slowly lower her arm back to her side. In doing so, we're looking to see if she can even control it. So if it drops right away, I'd be positive for rotator cuff involvement. Or if she starts to control it, but then suddenly it drops, that would also be a positive test. And it indicates that the rotator cuff muscles are have some sort of fault in this. So the drop sign or the dropping sign is used to assess specifically the infraspinatus if we're looking to see if there's rotator cuff involvement for the shoulder problems. So basically what we're going to do is have our patient come out into some external rotation at 45 degrees, and then with her elbow at her side. And then I'm going to give her resisted external rotation and have her resist me. And if she can't maintain this and drops out of it, then it would be positive for infraspinatus involvement with her problem. So this is the speeds test. It's to figure out if the biceps tendon is involved with the pain at the shoulder. So basically what we're going to do is I'm going to passively bring her up into about 90 degrees of shoulder flexion. And we're going to start off in supination. I'll ask my patient to hold this as I push down on her. And if this reproduces her pain, which she came here for, then we would pronate her, and then we will complete this again. And if my patient feels better in supination, if my patient feels better in pronation versus supination, then it would indicate that the biceps tendon is involved, and it would be a positive test. Alright, so this is the Jurgensen's test. It's basically to see if the biceps tendon is subluxing at the humeral head. So basically what we're going to do is we'll have my patient go into some resisted supination and external rotation, and in doing so I'm looking to see if the transverse ligament of the humeral head is compromised, which would be allowing the biceps tendon to sublux. This is what it looks like. And rotate your hand and bring it towards me. If I feel the biceps tendon subluxing or coming out of place, then it would be positive. So this right here is a posterior glide of the glenohumeral joint. We're going to do this to improve shoulder flexion and internal rotation. So how I'm going to do that is I'm going to come find my patient's AC joint, come right off of it to the head of the humerus. Then we're going to apply our force in the scapular plane to prevent further injury. And then we'll do grades 1 and 2 to help pain management, and grades 3 and 4 to help improve range of motion. So for a grade 3 here, what I'm going to do is I'm going to find R1, go into R2, come out of R2, and apply large amplitudes. And then this would be done, and it should help improve my patient's flexion and internal rotation of her shoulder. All right, so now I'm about to do an inferior glide of the glenohumeral joint. I'm going to be doing a grade 3, so that way with the inferior glide I can increase abduction. So I'm just gonna come under her AC joint, and then I'll go from R1 to R2, come out of R2, and do my glide. So this is going to be a lateral mobilization of our patient's glenohumeral joint. So basically what I'm going to do is I'll have her lying in the plinth like so, and then I'll have my proximal hand to her inside her axilla right here, and my distal hand will be on her humerus. I'm applying a loud distractive force as I use my body and my force to help distract her laterally. This is good for pain modulation and patients that are highly irritated. Okay, so now we're going to row the boat. This is a grade 2 mobilization for the glenohumeral capsule. So basically what we are going to do is we'll have our patient lying down right here, and we're going to passively take our patient's form right here. And I'm just going to go back and forth, rhythmic motion, having her arm come against my stomach as a point of reference. And we are doing this to help our patient feel better, pain management. And we're just going into the range that she's comfortable with. All right, so now we're gonna flop the fish. This is a grade 3 mobilization of the glenohumeral joint in the capsule. So basically what we are going to do is we're going to give rhythmic oscillations to our patient's shoulder, and we're going to take this in a pain-free range of motion, which she has available, and then the motions can be from ulnar deviation, like so. As treatment goes on and she feels better, we can increase the range of motion which we're working with and proceed.